Good evening, friends. Pradeep Pendyala, your buddy. Today I am going to talk about obstructive jaundice. I'll clear all your doubts about obstructive jaundice. That's my promise. That's my promise. Let's start. Obstructive jaundice produces a number of biochemical and physiological alterations in the biliary tract. Acute cholangitis occurs in an infected, usually obstructed biliary system at the level of the common bile duct. The most common cause of obstruction is stones. Friends, this is also known as stone disease. Gallstones may pass through the common bile duct and cause obstruction, and symptoms of biliary colic and cholangitis do occur. Larger stones can become lodged in the common bile duct and cause complete obstruction with increased intraductal pressure throughout the biliary tree. Obstructive jaundice has hallmark findings on the biochemistry profile. It is primarily a conjugated hyperbilirubinemia with the direct bilirubin more than 50% of the total bilirubin. There is also an associated elevation of alkaline phosphatase, friends. Now, in obstructive jaundice, both intrahepatic cholestasis as well as the extrahepatic obstruction, the serum bilirubin is principally conjugated, as I had just mentioned. The conjugated bilirubin is water soluble. I'm sure you're aware about it, and is excreted in the urine, giving it a dark color, bilirubinuria. That's the thing they call it. When the bile ducts become blocked, bile builds up in the liver, and the jaundice, the yellow color of the skin develops due to the increasing level of bilirubin in the blood. I'm sure you know these things, but let us go into deeper part of it. Because obstructive jaundice has high mortality rates, early detection is very essential. Diagnosis and treatment is essential. The tests which are performed in obstructive jaundice are CT scanning and magnetic resonance imaging. Blood tests definitely needs to examine the bilirubin level. Friends, the conjugated, that means the direct bilirubin level, is often elevated by alcohol consumption, excessive infectious hepatitis, drug reactions, autoimmune disorders, post-hepatic disorders also can cause conjugated bilirubinemia. Death from obstructive jaundice in the first few weeks of its course is quite rare and is only occasionally observed. After a period varying from 4 to 6 months, however, patients suffering from occlusion of the common bile duct usually deteriorate rapidly and they can also die. Patients with obstructive jaundice are inclined to develop nutritional deficits, infectious complications, acute renal failure, and impairment of cardiovascular function. Adverse events such as coagulopathy, hypovolemia, endotoxemia can be insidious and significantly increase mortality and morbidity. Friends, acute obstruction of the extrahepatic ducts causes cross-proximal duct dilatation and elevated levels of ornithine carbamyl transferase as well as bilirubin and alkaline phosphatase. Therefore, indirect bilirubin levels rise even in persons with obstructive jaundice. Both conjugated as well as unconjugated bilirubin fractions may increase in varying proportions. In obstructive jaundice, malabsorption of vitamin K results in hypoprothrombinemia and a fall in the concentration of other vitamin K dependent pro and anticoagulation factors. Laboratory assays are used to assess the state of coagulation system. In the brain, this oxidative stress may lead to neuropsychiatric abnormalities known as hepatic encephalopathy, which at the end leads to symptoms varying from tremor, behavioral changes to ataxia and coma, which are commonly which are eminently mortal. High value of APTT occurs as a result of the deficiency of vitamin K dependent clotting factors because in obstructive jaundice, uptake of vitamin K is impaired due to blockage of the bile duct. And this process, by extension, affects the efficient functioning of vitamin K dependent clotting factor. An accurate diagnosis can usually be made with standard diagnostic techniques such as physical examination and biochemical tests. When appropriate, gastrointestinal X-ray studies, cholangiography, cholecystography, and liver biopsy observation of the patient's course are very essential, including radiological. In cholestatic diseases where the blood flow is obstructed due to anatomical obstruction to bile duct flow, that is extrahepatic cholestasis, or impairment of bile synthesis by hepatocytes, intrahepatic cholestasis, a raised conjugated bilirubin level are thought to be associated with far greater elevation of ALP. Prognostically, a rise in precursor concentration indicates return of hepatic synthesis capacity. Return of hepatic synthetic capacity, even though the patient's prothrombin time remains abnormal. In practice, the prothrombin time may be prolonged more than 3 seconds over control value in both hepatocellular as well as obstructive jaundice. Stone disease is most common cause of obstructive disease, which I had just mentioned. Gallstones may pass through the common bile duct and cause obstruction. And symptoms of biliary colic and cholangitis can occur. Larger stones can become lodged in the common bile duct and cause complete obstruction with increased intraductal pressure throughout the biliary tree. I hope I have made it very, very clear. Even if some doubts are still existing, let me make it very, very clear. Friends, cholestatic jaundice or obstructive jaundice occurs when there is a physical or physiological obstruction to bile flow. The obstruction may be intrahepatic or extrahepatic. Intrahepatic causes of obstructive jaundice are hepatitis, drug intoxication, primary biliary cirrhosis, cholestasis of pregnancy and metastatic cancer, and alcoholic liver disease. Extrahepatic causes are biliary calculus, stricture of common biliary duct, stricture of common biliary duct, carcinoma of common bile duct, carcinoma of common bile duct, carcinoma at the ampulla of water. Many people call it ampulla of Vater, but correct pronunciation, ampulla of Vater. It is the opening of pancreatic and bile ducts into the first part of the duodenum. It is ampulla of water, although it's pronounced occasionally as ampulla of Vater, V-A-T-E-R. Pancreatitis or pancreatic pseudocyst, sclerosing cholangitis, and pancreatic cancer. This manifests as mixed hyperbilirubinemia. Some conjugated bilirubin reaches circulation and is excreted in urine, producing dark urine, as I had earlier mentioned. Since most bilirubin does not reach the intestine, pale or white or clay-colored stools are produced. Lack of bile salts leads to fat malabsorption or steatoria. Steatoria, that's the right pronunciation. Steatoria. Serum glutamic oxaloacetic transaminase, also known as SGOT, and serum glutamic pyruvic transaminase SGPT are normal. Serum alkaline phosphatase are always raised. I'm sure I have made it very, very clear. Thanks for patient listening. Until next time, goodbye. This is Colonel Pradeep Pendyala, Professor of Anesthesiology at Asram Medical College, signing off for tonight. Happy Saturday, happy weekend. Bye-bye, take care. Bye-bye.